Good morning. My name is Barbara O'Hanlon, and I'm the Senior Policy Advisor on the SHOPS project. This morning, I have the pleasure of introducing Faith Muigai, who is the Director of Jacaranda Health. And this morning, she will be presenting an innovative commercial model to deliver quality maternity services to the urban poor. Faith is a registered nurse and clinician with over 15 years of experience in clinical service with a focus on women's health, both in the U.S. and Kenya. This morning we're using a new technology for Network for Africa. We're using webinar. We hope that this will be a bit more dynamic. And so Faith will start this morning's session with a 20 to 25 minute presentation that you all can follow using the webinar software program. At the end of this presentation, Faith will take questions, and at the end of the presentation, I'll explain how you'll be able to make questions. So Faith, welcome to Network for Africa's webinar series, and thank you for presenting Jacaranda's experience.
Thank you very much. I'd like to thank the SHOPS project and Network for Africa for giving Jacaranda Health this incredible opportunity to present some of the good work we're doing here in Kenya. My name is Faith Muigai, and I'd like to introduce you to Jacaranda Health, a venture that aims to change the way maternal health care is provided in Africa. And just a bit of background, our founder, Nick Pearson, was working in Nairobi, Kenya with the Acumen Fund doing venture capital investing in businesses serving the urban poor. He met his wife here, an obstetric gynecologist working in Western Kenya, who described her friend's death during childbirth, which could have easily been avoided with better care. He then set out to launch Jacaranda Health. Myself, my background is nursing. Studied and worked in the United States for over 18 years in leading healthcare institutions such as Johns Hopkins Hospital, University of Maryland Medical System, and LifeBridge Health System in various capacities including direct patient care, research, program management, and executive management of patient care services. A young woman in Kenya is 100 times more likely to die during childbirth than a woman in Europe or the United States. Having a baby is more dangerous than serving a tour of duty in Afghanistan. By any standard, that is not right. And what makes it so tragic is most maternal deaths are entirely preventable. The World Health Organization estimates that you can reduce mortality by 75% by providing decent care with skilled providers. Today in this presentation, I would like to talk about what we do and our model, our progress and next steps. I would also like to review some of our innovations around patient-centered care, building world-class clinical systems, and our business approach. Next slide, please. Previous slide, please. I apologize. There we go. Lower income women in Kenya do not receive the continuum of quality care that prevents complications and leads to healthy birth outcomes. Less than 50% of expecting mothers complete the 4 antenatal visits recommended by the World Health Organization, and even a fewer percentage access that care during their first trimester. The availability of drugs and equipment is poor. Emergency transport is non-existent, and a number of deliveries occur at home rather than at an equipped facility. The 2013 Global Maternal Health Conference focused on quality of care for precisely this reason. The maternal health community is increasingly increasingly realizing that poor quality of facility-based care is one of the principal barriers to improving maternal and neonatal outcomes. Jacaranda's mission is to address key gaps in health systems at a facility level, to provide quality care which include human resources, information systems, quality management systems, and clinical protocols. There is an opportunity. Millions of dramatically underserved women want and need a better option, high quality, affordable maternity care that is respectful of their dignity. And that is precisely what we are trying to do at Jacaranda Health. In Nairobi alone, 2/3 of the city, over 2 million people, live in low-income peri-urban slum areas where health conditions and availability of medical services is poor. In these areas, the socio-economic and family landscape is fractured. Poor environmental and sanitary conditions are the norm. Gender violence and adolescent pregnancy is high. We conducted primary and secondary research on maternity facilities within our catchment region and came to the conclusion that they're severely lacking sufficient maternity facilities in terms of both quantity of facilities and quality of services provided. Most facilities are private enterprises, with the standard of care anecdotally reported as questionable. Public facilities in our catchment area have poor reputations for both quality and friendliness. Jacaranda's solutions include outreach models to both educate the community and provide access to quality health services. Our initial approach has been mobile clinics that go into the community and provide friendly, easy-to-access prenatal, postnatal care, as well as family planning services. We have standalone hospitals staffed by experienced nurse midwives who provide respectful care and facilitate safe deliveries. This slide conveys a story of a client who accessed our services. Our community outreach model provides awareness and pulls clients to our services. Upon accessing our services, an ongoing relationship is built with our skilled and trained personnel. Birth planning and various forms of relevant education are provided through the scheduled visits. Evidence has shown that a lack of family planning education and methods contributes to poor maternal health due to babies spaced too closely together and incomplete and unsafe abortions. Having said that, family planning education is incorporated in overall education along the continuum of antenatal care so as to engage women on their options during the postpartum phase. We have used various modes of technology to assist in reminding clients of their scheduled visits and provide educational tidbits. Our patient-centered model calls for spouse and family involvement in our client care. The goal is the client's delivery in a facility that is equipped and staffed with skilled providers. We engage our clients to ensure bonding, postpartum care for herself and her newborn. We provide home visits, an area I'll expand on later, to ensure that the transition home is safe and schedule them for return postpartum checks as well as child wellness immunization visits. Our team. When I say we, this is what I mean. Our team of staff, consultants, volunteers, interns, advisors. We place great emphasis on our workforce as they are our frontline and foundation. We take great stride to ensuring staff satisfaction in order to ensure patient satisfaction, promoting professional development and additional innovations in the areas of task shifting at the bedside and with our home visit programs. Building human resource capacity for quality care is a key component for our model replicability. We are designing training curriculums for nurses, our patient care assistants, our community health workers that use best practices. Jacaranda's mission is to become East Africa's first truly low-cost, sustainable, and scalable maternal health delivery company for low-income women. Our goal is to build a network of 20 to 30 maternity hospitals in Kenya that provide women with affordable, respectable, high-quality, comprehensive care. Our pricing model is simple. For antenatal services, what we could term as prenatal service and consultation, including labs, we cost that at about 500 shillings, approximately $4. Follow-up visits for ANC or postnatal consultations are at around 100 shillings, about $1. Our normal delivery package, inclusive of bed and meals and postnatal visits, ranges at about 7,900 shillings. This is less than $100. Just for reference, average cost of delivery in most private hospitals ranges from 10 to 50,000 Kenyan shillings. Our largest public facility in Nairobi, a default option for low-income women, charges around 4,900 shillings for delivery and approximately 6,500 inclusive of bed charges and additional costs. Now this has recently changed with the charge of free maternity in public hospitals. But this then raises the quality issue as public facilities are overburdened as we speak. Deliveries therefore are our main source of revenue, and for us to break even we need to approximately have 100 deliveries a month in our inpatient facilities. We want to demonstrate better, more cost-effective ways of providing maternity care that can be replicated by the private sector and government ministries of health. In the long run, that's where we will achieve our biggest impact. Next slide, please. So let me tell you 3 things that makes Jacaranda's model special. First, a relentless focus on building systems for clinical excellence. The only way to deliver a baby for less than $100 and maintain a level of quality that our international advisors are happy with is to be highly protocol driven. One example that's generating a lot of interest in our electronic medical record systems. Our nurses enter data into mobile phones to create patient records. That gives us an incredible window into our operational and health metrics and provides step-by-step decision support to our clinicians. Secondly, a business-like approach. I'm going to spare you our market research slide deck on our mind-numbing financial spreadsheets, but those are what guides our strategy for growth and makes us more accountable and transparent. We want to be able to say we can deliver a baby 50% more cost effectively. And in a day when there is a 40 billion global shortfall of government funds for maternal health, that would be really powerful. The third is our patient-centered approach. We are not simply providing great customer service, but actually a service designed by women themselves. We engage in human-centered design to create an experience that is client-focused. We engaged experts from academic centers, for example, University of South Carolina, to apply lean methodology and continuous quality improvement to improve operational efficiency, increase patient safety, and reduce risk. Monitoring and evaluation is key to track our progress and benchmark our services against other providers, both local and international. Partnerships with key organizations have been beneficial to providing us with baseline data that equally influence our strategy and measurement of impact. Next slide, please. Next steps. We are still in the early stages. We have several hundred very happy customers from our first hospital and setting up our second and third, hopefully by the end of this year. But we have laid the building blocks for scale. Most importantly, a team that can execute on this vision. Over 40 staff, both local and international, world-class management and experience in marketing, obstetrics, finance, and human resource, experienced nurse midwives. The systems that I mentioned, protocols, human resource operations, cash controls, IT, electronic medical record, our advisory committee, some of the most respected names in the maternal health space. Partnerships, for example, with Harvard School of Public Health, to measure the social impact of the work we're doing. We are really poised to change the way that maternal health care is provided. Next slide, please.
Is this the right slide, Faith?
Next slide, please.
Going after you.
Thank you. Okay. And so a few of Jacaranda's key innovations. Services designed to increase client satisfaction. As I mentioned earlier, we take a human-centered design approach, and so we include our customer in the design of the services we will deliver in order to ensure that we're providing, we're catering to their need. One of the areas that we have focused on as well as we engage family and spouse involvement is a human-centered design approach to male involvement in order to drive and engage spousal involvement along the continuum of our antenatal services, delivery, as well as postpartum and family planning services. With this slide, you see we have patients designing an ideal waiting room. And so once again, we're showing that our customer is focused, our customer opinion is key, and we incorporate that in all that we do in order to provide a service that is customer focused and centric. We've conducted interviews in the field, conducted focus groups. This is the main way of collecting research and finding out what's happening in the communities and bringing it back to our facility as we strategize our way forward. Customer service, respectful care, ensuring our environments are conducive to our team delivering safe, human-centered care. We look at nurse-patient ratios. Our facilities have a nurse-to-patient ratio of 1 to 2. Maternity being dynamic, patient safety is key, and having a staffing ratio that allows for our clinical team to adequately assess, intervene, and refer when necessary. The other area is having available equipment and supplies in order to provide an efficient and safe environment to deliver care. Understanding our users, as I mentioned earlier, market research. We're trying to understand the population we serve. I mentioned early free maternity care. And what we try and understand is why do our clients opt for certain services than others. My first entry into the public health sector was a woman laying with no sheets. The nurse was at the other corner of the room. The woman looked literally like she had delivered on her own. And yet with free maternity services, we see women, underserved women, flocking into situations that are considerably unsafe, considerably putting themselves at risk and considerably undervaluing themselves and the quality of services that they deserve. Testing new technologies. We view Jacaranda Health as also a laboratory for some of the most exciting innovations in maternal and child health, including the systems that support health service delivery. We test innovative practices from around the world in mobile health, evidence-based medicine, electronic medical records, and financial and marketing innovations, and measure their impact on quality of care and health behaviors. Those that are proven successful get integrated into our model, helping to drive the iteration of a replicable model for high-quality care at a low cost. As you see, this is a slide that shows us discussing exams, lab tests. What am I saying? We conduct regular continuing medical education, case reviews, audits. As I mentioned earlier, continuous performance improvement is our goal. We're continuously learning from our day-to-day practice and striving to do better, and therefore we engage our frontline in looking at the work and looking at the service we're providing and looking at ways we can improve our service delivery. A few innovations from our patient design process, education in the waiting room has been implemented, continuity of care with the same nurse, just to gain that trust and bonding with the client. More time for counseling, so we provide more time to be able to educate and answer questions for both client and family. We also provide tools to help save money for delivery. Building a world-class clinical systems to improve quality of care. We've had input from key both local and international experts to advise us as we strategize, develop our clinical protocols, and focus on our service delivery in terms of safe care. We get input from frontline staff. We include them in the design process. If you look at our clinical protocols, our documentation, the patient flow in terms of architectural design, our frontline staff have been key in providing input. Not only is this to provide safe care, but also an added value to including our staff in decision making and in building this really great model of care here in East Africa. As we talked about rigorous clinical protocols and checklists to ensure quality, to help our clinicians in decision making, give decision support as well, to ensure that they're providing safe care and making the critical decisions that would in effect have a huge impact on outcome. Electronic medical records and mobile phones, as I said, innovation, technology, those are key components in trying to not only assist in decision making in the clinical processes, but help in data collection as we go back and look at our services, benchmark with other facilities, both local and international, and ensure that we're taking strides to making an impact. Another slide that shows that our staff is involved on an ongoing basis in quality improvement initiatives. Building efficiency, we include rapid point-of-care testing. We try and make ourselves a one-stop shop, so not only do we include rapid testing to ensure efficiency in our services, but to be able to build time, to be able to provide the necessary education and so forth. Most of our client feedbacks has been that they want a one-stop shop. they don't want to come to a service provider and then be sent to another and another on a wild goose chase. They'd rather come to a one-stop shop where they can come, receive a service in a more efficient way, receive the necessary education in a more, once again, patient-centered environment and dynamic. A business-like approach to sustainability, our model removes financial barriers in 3 ways: by using innovations and systems that lower overall cost, tax shifting, technology, protocols. We are also seeking accreditation with the National Health Insurance Fund, as 30 to 50% of our customers are card holders. We are also offering financial options, including our what we call our Mama Kiba Savings Scheme, which is a mobile banking scheme to help expecting mothers save for their deliveries, spreading out the cost of fee over a longer period of time. We talk to our customers and say, if you can afford to save 30 shillings a day for 9 months, you definitely can afford the quality services provided at Jacaranda. And this is what our competition looks like. Marketing materials designed with patient feedback. Part of building our business involved a significant focus on marketing and getting the word out that we are an organization that is here to provide affordable, safe maternal care. But on the other hand, also providing opportunities to attract our customers to our quality services by offering promotions and referral bonuses to encourage that word of mouth. Building credibility in the community and establishing trusting relationships. We've heard from our clients that churches are places of trust, and therefore building ongoing relationships with critical entities in the community so that we can have the opportunity to talk about our services and draw our clients to our quality services. Jacaranda Maternity, I'm proud to say that these are our clients and these are who we serve. Thank you.
Thank you, Faith. That was a terrific presentation on what Jacaranda is doing to address safe delivery and well baby care to the urban poor in Kenya. Needless to say, your excellent presentation has generated several questions, and I'd like to start by one of the easy questions which I can answer for you, and this is from May Castor, who says, may I have a copy of this presentation? And the answer is definitely yes, and if you were to go to the Network for Africa webpage on the SHOPS website, we will be uploading the presentation as well as the transcripts from this presentation. But for a more challenging question, I have the first one from Jessica Bowers, who is thanking you for a presentation, and she wants to know, how are you working to ensure that Jacaranda is strengthening country capacity over the long term and not creating a parallel health system? Are you working with the government?
We are partnering with the government in different ways, and as there becomes an increasing focus in maternal health, I believe there will be opportunities for what we call private and public health partnerships. And so in ways that we've partnered, we actually sit under the district local government, and therefore the district health medical system is our overseeing body, and we have used our site to conduct outreaches with partnership to the government. I myself, as clinical director, sit on the National Reproductive Health Task Force and so forth. So there ways that we are partnering and exchanging ideas. But we look, as maternal health becomes an increasing focus, particularly in Kenya with free maternity care, I anticipate that greater partnerships will be developed as we go along.
Okay, we have another question from Robert Yates. It sounds as if your services are financed by the users and that they are paying out of pocket. Doesn't it concern you that this is the most inefficient and inequitable way to finance health services and that you will not really reach the poor?
Could you repeat that, please?
No problem. It seems like Jacaranda is financed by out-of-pocket payments from your clients. And the questioner wants to know, are you concerned that this is the most inefficient and inequitable way to finance health services, and that if you are really able to reach the poor?
Right now we're looking at a variety of different investment options, and therefore as we scale, and right now we're about a year old once again, so it's also still proof of concept, and therefore we're also trying to understand our unit economics. In order to scale, we are volume driven, so we have to have a set number of deliveries to break even and drive our organization forward. But once again, as indicated, we're looking at a variety of different investment options, and that's actually something we'd be happy to talk offline about. But once again, in the stage that we're in right now, we're actually trying to understand our unit economics. We are looking to expand to Hospital 2 and 3 by the end of this year. And with that, we're looking at how to drive our volumes to sustain our business as well.
Okay. Thank you. And I also wanted to reiterate your point that if I heard you correctly, 50% of your patients are covered by the National Health Insurance Fund, so that
Correct.
In fact they are not paying out of pocket, but are being covered by the National Health Insurance Fund. And is Jacaranda also participating in the voucher program in Kenya?
Jacaranda is not eligible at this point to participate in the program, mainly because it was vetted in specific areas in Kenya and Nairobi. And therefore, right now, in terms of other payers, the National Health Insurance Fund is really what we will rely on.
Okay. Referring to the first question, there is a follow-up comment by Mbogo Bunzi in Shops, Kenya, and he says, my thoughts on the question asked about building the health system. The private sector composes between 40 to 60% of healthcare in Kenya. When Jacaranda focuses on providing quality maternity care in the private sector, they are helping build the health system. So that's another comment on whether or not Jacaranda is actually helping or building a parallel system. Let's go to another question from Anina Van Wingard. What type of tools do you provide to help clients for safe delivery?
Could you repeat that, please?
What type of tools do you provide to help clients with safe delivery? I hope I got the question right.
What type of tools do we provide clients?
Yes, to ensure safe delivery. So I think the question is focusing on how do you work with the consumers to ensure that there is a safe outcome for their delivery?
I think our focus, and once again, earlier in the slides, I talked about access. So women are consciously not accessing healthcare facilities for a variety of reasons. And therefore, we are trying to go out into the communities to provide that education to dispel myths and so forth, and actually attract women at early stages of their pregnancies to skilled services and skilled care. And that's where our outreach model come in. So that's Jacaranda going out in the communities and actively touching clients and educating them on why it's necessary and why it's important to come into a skilled delivery when they're term. So actually going out and engaging women earlier on in their pregnancies is one of our key strategies.
Okay. There are several questions that are interested on the socioeconomic profile of your clients. We have one from Jarav Katwal asking, do you see clients who are the poorest of the poor, clients who do not have health insurance or money for your services?
I would honestly say we don't see clients who are poorest of the poor, and that's where the public and the private sector come in. We see clients who would on average make, say, $3 to $4 a day on average. So lower income, but not poorest of the poor.
Okay, great. We have a question. Now we have a series of questions about some of your clinical work. There's a question from Dr. Charles Aninweze from Abuja. And talking about clinical protocols, how are you relating the reduction of maternal mortality with some of the major causes found in Africa? Examples such as hemorrhages, eclampsia, sepsis, obstructed labor. How do you define your approach? And that's the end of the question I have. So, focus on ANC as against the routine ANC.
I feel that there are two questions there.
Yeah.
One is our approach in terms of our model of providing ANC services, and then the other had to do with clinical protocols and how we address what I would, if I was hearing correctly, complications such as PPH, eclampsias, and so forth. Am I on the right track?
Absolutely.
Okay. In terms of provision of ANC services, we are looking at a variety of models. We traditionally have engaged on one-on-one ANC where we are trying to encourage spousal involvement or family involvement in those visits as a holistic approach. But we're finding that, or we're understanding that a peer approach might also be beneficial to provide that sort of support environment where women support each other and have this sort of what they would call like a chama, so and that's in Swahili, but sort of like a support sort of entity through their pregnancy. And those are models that we are looking as we develop to incorporate, because as evidence shows, they seem to be valuable in terms of also sustaining women through their ANC visits along the continuum of their care. So we've started with the traditional one-on-one approach where we're really trying to engage spouse and family involvement, but we're looking to transition or add a variety of other avenues of providing these services to increase compliance and also to increase that support as well. In terms of our clinical protocols, not only do we use World Health Organization guidelines, but we use evidence-based guidelines that have come from key academic entities in developed countries. But we also have to pare them down to apply to our setting because we are a low resource setting. When we talk about clinical protocols, our documentation and so forth is so detail oriented, but also very prescriptive to be able to help our clinicians in recognizing complications earlier. We also do have a set of protocols and algorithms that support the documentation, and therefore that helps cue our clinicians in decision making and making necessary referrals if need be to higher levels of care in the management of those cases.
Okay. I have a question from Francisca Zanga and from Kenya, and he would like to know a little bit more about the Akiba savings scheme. Is the 10 shillings deducted from the M-Pesa, or is it sent to Jacaranda directly? Or is saving contributions done monthly?
So we encourage our clients to contribute at any time, so not necessarily monthly, but they can also contribute more than that. And so what we are trying to do is change behavior. I'll tell you, for example, most of our clients, or a lot of our clients that I've seen, come in on their 9-month and it's a surprise. The pregnancy is a surprise. And we definitely know that this is not. And therefore, what Jacaranda is trying to promote is changing behavior and actually taking responsibility and empowering our clients to take ownership about themselves and their newborn baby who's coming. And therefore, we have a pre-savings plan, mobile, M-Pesa, mobile money, that goes into a Jacaranda account where they can deposit however much they want and feel comfortable through the continuum of care, through their antenatal care, to be able to save for that safe delivery. And if that client is unable to deliver with us, those funds are provided back to them to deliver at a higher level of care if need be.
Okay, the questions are coming in fast and furious, and we'd like to apologize in case we don't get to all of them. However, Faith and Network for Africa will commit to answering them even offline, and you'll be able to see your questions answered post the webinar. Here are some more questions about the financing of Jacaranda. The first one is, this is a great initiative. One challenge, and this is from Eugene Amase. This is a great initiative. One challenge in developing affordable services is raising the initial startup funds to finance the service. How did you overcome this? What would you regard your company as, a not-for-profit or for-profit?
There was a little breaking up, but what I'd like to emphasize that we are a for-profit organization licensed in Kenya, and therefore we depend on our business model to be able to break even and sustain the business. I can't say we have gone over that hump, and therefore what I'd like to emphasize that we are at a stage where we are still trying to understand our unit economics, and would be at a better position after sort of clinic number 5 to answer that question. So we are a work in progress, but we do understand that to be sustainable, we have to have this business model where volumes and breaking even to be able to sustain our business is essential and key. And therefore, we do have a financial strategy that we are focused on.
So a follow-up question on that from Jeff Barnes is, when do you expect to break even, and when are profits expected?
One second. Our goal is to break even by clinic number 15, and so we're at clinic number 2. Okay. And then when we talk about, and right now our scaling strategy, so we have to have 3 hospitals running by the end of this year, demonstrate that the systems can scale, and then add several more, including other cities next year. Once again, I really want to emphasize that we're still in the process of understanding our unit economics. So I cannot give you a definitive. And what I can give you is speculation, because we still are on our journey to breaking even and really proving that our model works.
Okay. I'd like to come back. There's a question about scale, but I want to come back to one point that Eugene asked, which was what funds did you use for initial startup to finance Jacaranda to get this model going in the first place? Was it commercial funds, donor funds?
We initially we initially set forth with some seed donor funding, but at this point we're operating as a business, and we are looking at our current costs, and
so you used there was initial funding from an investor.
350 to 400 outpatient clients a month, and we're at around 30 to 40 deliveries a month. So we are on our way to where our trajectory is telling us, and with that we are understanding costs, but trying to contain costs to be able to sustain the business as we speak.
Okay. You had mentioned, Faith, that you all are now in the process of not only understanding cost, but whether this model can be scaled. I have a question from Pauline Irungu in Kenya, where she states there are cases of private providers who start off offering good quality services, but as they expand, the quality goes down. Mm-hmm. What are you doing to hedge against this happening as you expand your services?
I think, and I agree with Pauline, but I think where the emphasis, and when you look at our slides, there's cost efficiency, there's quality. So we are not only are we trying to build efficiency into our systems, but we're trying to drive our costs down. And therefore, we have embarked on quality initiatives where we are mapping out our processes, looking at our inventory, and so forth. So that constant reevaluation of our systems and what is driving costs and how can we provide the best care in a most cost-efficient way, I believe is our mantra. And so I can't comment for other organizations that start up and then fail to produce. I can say that part of our philosophy and part of our team is that ongoing analysis of costs and how to be efficient but provide safe care, and that is an ongoing task for us, and one that I say that we will not one that I can say that we will continue to do, particularly when we talk about quality as being our part of our core values.
Okay. I have a question from Ali McLean from the Micronutrient Initiative in Canada. She states, your presentation mentioned that Jacaranda is testing technological innovations and incorporating them. Can you comment on which ones you have used and which ones have worked and haven't worked?
The technology side is an area that once again we're also working on. We've used systems where we are entering data on mobile phones using a platform, ComCare, that allows us to enter data for our outpatient visits. And with that, we're able to go back and analyze the care, time for visits, analyze trends, and so forth. We're also engaging with a platform, Salesforce as well, looking at ways to integrate systems, not only clinical, but also on inventory supply management and so forth. So once again, the technology aspects is also a work in progress, but our commitment is there, having hired an IT operations manager and so forth. So not only are we engaging in some of the systems, but from a workforce end, we're onboarding experts to be able to help us devise the most efficient systems to do what we need to do. So right now, once again, our mobile phones and ComCare is an area that we engaged in inputting data into mobile phones in our mobile clinics as well as in our inpatient clinics, and analyzing them on the back end to help us strategize and trend data and so forth. And another area that we're looking to engage in is Salesforce, and that's not only integrating clinical, but it's looking at our inventory management and so forth. And that has to do with our efficiency and costs and so forth. So once again, we're trying to look at our services along the continuum to look at what we're doing and how we can do better.
Okay. I think this is another technology question from Toby Tullis in the United States. What EMR are you using? What are the connectivity requirements?
Wow.
Electronic medical records. I just figured that out.
Being very clinical, I would say that that's a question I would be happy to answer an email where I have the support of our IT manager to answer that.
Okay. All right, Toby. So stay posted. We'll get you a response to that. I have a question from Latonia, and she wants to know, has Jacaranda the program been evaluated?
Has the program been evaluated by whom?
That was not part of the question. Let me see. When did you do it? Oh, okay. So I think that she didn't ask by whom, but she's in particular wanted to know when did you begin the education in the waiting room program? How well is this program working? Who are the educators? For example, are they community health workers or registered nurses? And has this approach been evaluated? So Latonia's question about evaluation is on your consumer education in the waiting room.
So in terms of formal evaluation, I would say no, but I can tell you that everything we do, we try and position ourselves for greater accreditation. So in terms of the Safe Care and the JHI International, those are things that we're aspiring in terms of accreditation and an evaluation. In terms of educational evaluation, I could say no formal organization has done that, but we do formulate our curriculums and our tools from a lot of evidence-based material, and I would start with the World Health Organization being a huge part of that as well. Who are educators? They are our nurses, but that's an area where we're trying other innovations, where we're engaging support staff such as community health workers and what we call patient care assistants, who are trained by our nurse midwives. And with that, a curricula is developed. Pre and post testing is done to affirm understanding of the material that is being provided to our clients, and ongoing evaluation on an annual basis to ensure annual competency. And therefore, this is an area that we are task shifting to our support staff to offload of
Faith, we just had you, Faith? Faith?
Yes, I'm here.
Okay, I'm sorry. We just lost, you were explaining about the educators are patient care assistants educated by midwives, and that's the last.
Correct. Once again, this is an area where we have tasks shifted, and therefore predominantly our community health team, as well as our patient care assistants, trained by our nurse midwives, with pre and post testing and annual testing to validate or reinforce competency. So that is our team who provide education in our waiting areas.
Okay, we are quickly coming upon the end of the hour. We have time for one question, and so Faith, if you can keep the answer short. Once again, we want to tell our participants that we will answer your questions, and so you can see them if we did not have a chance to get to them during this hour. So the last question is from Asma Khalid and Marie Stokes in London. And the question is, do you have agreements with facilities for accepting complications? Are these agreements with government facilities or other private ones? Who pays for the transfer and management of complications?
Okay. We have agreements, some formal, some not. But part of referring our patients to a higher level of care was ensuring that we had a tight referral base. And therefore, we have agreements, or we have understandings with both private and public payers. We have facilities that we would recommend, but it also depends on what the client can afford as well. There was a second piece to that.
Can you go back, please?
Yeah.
So,
who covers the cost?
That is correct.
That is an area that right now, in terms of patient safety, we absorb the costs up front and go back to collect on the back end. But client safety is priority, and therefore we absorb costs up front, and then we go back and collect on the back end. Needless to say, in terms of referrals, with the number of deliveries we have, on average, we have probably 1 to 2 a month.
That are complications, or with complications.
That are complications that need to be referred out. Others we are able to manage.
Okay. All right. I would like to, on behalf of the SHOPS Project and Network for Africa, to thank Faith Muigai again for an excellent presentation and for humoring us with learning this new technology. I'd also like to thank the participants for your provocative and interesting questions. Faith and Network for Africa will work with Faith to be sure that all the questions will be answered. And once again, thank you, Faith, and thank you, Jacaranda Health. And we look forward to the next webinar with Network for Africa in 2 months. So please stay posted on the Network for Africa site, and we'll make announcements of the next technical presentation.
Thank you. On behalf of the Jacaranda team, we'd like to thank you for having us on this presentation.